Perfect. So we're live. So good afternoon, everyone, and thank you for joining today's Public Health Lunch and Learn session. I'm Jordan Francis. I'm a Senior Public Health Officer at Birmingham City Council, and I'm joined today by my colleagues Kelly and Darlington from Aceso Global Health Consultants, who have been a key part in this work to date. So today we're going to be looking at how we're improving demographic data collection in Birmingham, including why it matters, what we've learned so far, and importantly, what happens next and what this means for you in the webinar today. Before we get into it, just as always, a few quick housekeeping points. So we'd ask if everyone can stay muted and turn off any VPNs where possible, just until the Q&A section, as it just helps things run smoothly and it helps with connectivity. We have both the chat function and the Q&A function enabled if you wish to ask any questions, but there will also be the live Q&A section at the end if you wish to come off mute and ask questions then. The slides will be shared after the webinar via anyone that signed up through Eventbrite, and the session is being recorded and uploaded to the Healthy Brum YouTube channel for watching afterwards. So a quick overview of what we're going to be going through today. So I'll start by setting the context of why this work is needed, what we're trying to improve, and why it matters. Then we'll hear from Aceso, who will talk us through the redesign process to date. And finally, I'll come back and talk a little bit about the next steps and, more importantly, how you can get involved. Before we begin, I just wanted to acknowledge the many partners who have contributed to this work already. This has been a genuinely collaborative effort from Aceso to all of the members of the Better Data Group over the last 12 months, the support from Kesh Academy in engaging young people in this work, and all of our community deep engagement partners, many of whom contributed multiple hours and in-depth one-to-one conversations to help shape some of the sections of the new tool. And also a special thanks to Allies Network for facilitating the in-person focus group sessions and participation sessions held last year, which contributed to some of the great kind of depth of qualitative findings that we had from this stage of research. So on to the context of why improving demographic data collection is a current priority for Birmingham, what the problem is that we're trying to solve, and what this means in practice. So there are several things that kind of contributed to this project to date. And this work, from my perspective, has been rooted in the BLACHIR review. So for those not familiar, that is the Birmingham and Lewisham African and Caribbean Health Inequalities Review. This review focuses specifically on addressing racial health inequalities in healthcare, initially centred on African and Caribbean communities. The review identified 39 key opportunities for action across 8 thematic areas and 7 core themes to be addressed, including a focus on better data. One of the consistent messages running through the review is that without good data, we can't fully understand inequalities, we can't target services effectively, and we can't effectively measure whether we're making progress. So although this work started with a specific community focus, the improvements we're talking about today are relevant across all Birmingham communities. One of the key issues identified in the BLACHIR review sits within theme 3, which is better data. And this theme is very specific on what it's asking for. It calls on the health and wellbeing boards and its partners to strengthen how we collect and analyse data so that it's more granular and culturally sensitive. At the moment, many of our data systems are quite outdated and still group people under very broad categories, for example, Black, other, or historically even BAME. As the review highlights, that approach doesn't necessarily reflect the real cultural differences between communities, for example, between Black African and Black Caribbean populations. So what happens is those differences get lost in data. And this affects how we understand health risks, how we understand people's experiences of services, and ultimately the decisions we make. The review goes a step further and outlines a very practical opportunity for action, which you can see on the slide. It suggests piloting the removal of colour-based language in ethnic coding, so that would mean taking Black Caribbean into just Caribbean, and then evaluating how that affects both participation and people's experience of providing data and trust in those systems. And that's important because it shifts from us just collecting data in the ways we always have done to actually sitting down and reflecting on, does this approach work for the people that we're collecting it for? And the other key message here from the review is that it can't be done in isolation. The review is clear that working with professionals and communities who represent these groups is essential to getting this right. So overall, BLACHIR provided the foundations for this project around collecting better and more meaningful data in a way that people recognise themselves in. So building directly on that, this slide sets out the core rationale for the project in a more broad sense. At the centre of this is what is described as data invisibility, where poor quality or incomplete data means that some communities are not properly represented. In a city like Birmingham, that's particularly important. As you can see from the 2021 census data, Birmingham is now described as a super diverse city with 51.4% of residents from minoritized ethnic communities, an increase of almost 10 percentage points from 2011. So if our data tools don't reflect that diversity, we risk missing insight on over half of our population. Now, we've already taken some steps in the right direction. Sorry, I'm just going to mute that as that's quite distracting. Sorry. So now we've already taken some steps in the right direction by redesigning the council's demographic questionnaire back in 2024, and that involved a citizens involvement panel and included the pilot recommendations from the BLACHIR review around the ethnic coding. But through feedback, we still identified some issues around how the tool wasn't fully inclusive, it wasn't easy to analyse, and it wasn't consistently used across services. On top of that, the policy context that we work in has evolved. In June last year, a full council motion was passed to include Sikh and Jewish identity categories within the ethnicity data collection of our services. For those who are unaware of the motion, I will recap some of the main points included from the report. So the segment of the report reads, Sikhs and Jews can be considered both ethnic and religious groups under the Equality Act 2010. Despite this, ethnicity data is not routinely collected by public bodies, and the race disparity audit found that of 340 data sets held across government, none included data on Sikhs. More comprehensive data collection on Jewish and Sikh residents will allow us to more effectively meet our public sector equalities duty, better understand the communities we serve, tackle inequalities and discrimination, promote equality, equitably deliver public services, and allocate resources fairly. Birmingham's estimated 2,000 strong Jewish community and over 30,000 Sikh residents make an enormous contribution to the culture, diversity and prosperity of our city and should be supported to identify as they choose. And this motion made Birmingham the first local authority in England to commit to changing the way that it collects ethnicity data. So this project brings together all of that, the BLACHIR recommendations, feedback on the existing tool and policy changes to create something both more inclusive, consistent and genuinely useful to data holders, because ultimately having a better data system creates a stronger foundation for fairer services across the city. Oh, sorry, I've just seen in the chat to slow down, of course. So why does this matter right now? As I briefly mentioned, local authorities have a statutory duty under the Equality Act to understand how services impact different groups. We're also increasingly expected to use data to inform consultation, service design, and commissioning. If our demographic data isn't accurate, we can't clearly demonstrate fairness, we can't evidence need properly, and we risk designing services that don't work for our residents. Looking at this from a health lens, frameworks from the NHS, such as the Core 20+5, rely on us being able to identify which communities experience these poorer outcomes and whether services are reaching them. The framework asks systems to focus on the most deprived 20% of the population, plus locally defined groups who experience poorer outcomes. This may include racialised communities, people with learning disabilities, and others who share protected characteristics as defined by the Equality Act, and also 5 clinical areas of focus, but we won't be touching on that today. In practice, what this means is local systems need to be able to answer very basic but critical questions. Which communities are experiencing poorer outcomes? Are services reaching them? And are we improving things over time for our residents? In a city as diverse as Birmingham, that requires granular and accurate data. Otherwise, we're making decisions based on an incomplete picture and guesswork. So improving data completeness and accuracy on our local populations can enable benefits for all, with a few examples listed on the slide here, as I'm aware we have representatives on the webinar today from different sectors, different organisations, and maybe some members of the public. So this project specifically focuses on one core aim, to develop a consistent, inclusive and analytically useful approach to demographic data collection. As outlined on the slide, we focused on 4 main areas. So participation, examining how the redesigned tool influences engagement and response patterns across different demographic groups. Lived experience, assessing whether wording, structure, and response categories are perceived as clear, respectful, and reflective of users' identities, while also being practical for those collecting the data. Analytical value, determining whether data generated through the revised tool provides meaningful, reliable, and actionable insights for analysts and service planners. And identifying good practice, developing an evidence-based recommendations to support consistent, inclusive, and operationally feasible demographic monitoring across Birmingham. The slide also briefly outlines what is covered by this project at this stage, which includes the design, testing, validation, and both community and professional perspectives. What is not being covered here is clinical data systems or electronic patient record redesign, wider data governance infrastructure, or the collection or analysis of health outcomes data. So this stage of the process does not seek to redesign wider data systems or clinical information platforms, and is at the minute just focusing on the demographic data collection. So that sets out some of the overarching context. So I'm now going to hand over to Aceso to talk through the bulk of the work in terms of the redesign and the new tool, and then I will finish up with the next steps. So Kelly and Darlington, over to you both. Thank you.
Thank you, Jordan. Hi, everyone. I'm really pleased so many people are on the call. We've been looking forward to sharing our information with you. I'm Kelly Webb-Martin. I'm one of the directors of Aceso, and with my colleague, Darlington, we will walk through some of our processes for this. We know that our part is just a small part of the bigger council program, but we're very happy that we were involved and learned so much in the process. So if I move on to the next slide, just briefly, just so that you know who we are. We are a sort of boutique-styled consultancy. We do a lot of academic research, such as NIHR, Wellcome, that sort of stuff. We do a hell of a lot of needs assessments and reviews. And of course, we're always engaging in grant writing and quality assurance processes with our partners. For this particular project, this is just a really flash summary of what we've been able to do, which is all the participants, 325 plus, all the deep engagement partners. We're so grateful for their engagement. And of course, the evaluation stages, it's around 7 that we've had on this project. So in terms of how Aceso works, because we are very much organization that works globally, so we use a lot of sort of innovations from a lot of our global partners in what we do, as well as the best of sort of UK evidence-based practices. And so we have a real sort of preference with co-production and working in a sort of a PLA format. So we've used elements of that in this particular project. So there was a process, which is the PLA cycle, which I'm sure many of you are aware of, where we work through the baselining, whatever data that we've got, etc. And then we go into the elicitation stage. We have a lot of co-production all the way through validation, operational finalization, and then the final reporting. So that was our processes. And I wouldn't go through it in great detail. I think the most important thing for us was the co-production aspect of it, to ensure that all partners and the local community, resident voices, was steeped in all the decision-making. Their data was very much prominent in the next steps that we take. So for us, the PLA process was really fundamental to how we manage this project. Thank you. So just in terms of our project governance, with Jordan, we were able to set up a core group, having the deep engagement partners as key members, alongside a number of council and NHS partners. And this was really helpful because obviously you get a 360 perspective when you have that sort of varied and diverse membership. So we were able to communicate routinely with over 50 members through our minutes as well as the core group meetings. And we met monthly, routinely, and our last meeting was in May 2026. Obviously, Good Jordan and I led a lot of that meeting, with me chairing and we had very active decision making throughout every stage. And we're really grateful for the representation that we had. And obviously, the slide just demonstrates some of the deep engagement partners. And I know that there is a ongoing sort of commissioning of this sort of work, which I think is excellent practice. And because we've worked across many local authorities, I have to say that the experience of working with deep engagement partners in this particular project was really what I would consider best practice. Thank you. The next slide. So we mentioned the sort of 7 stages that we use as part of the project. So just that in terms of the numbers, we had around 282 in terms of the survey. We had 29 participating focus groups. We had, obviously, we just said 29 overall in terms of the PLA and the in-depth kind of information that we got. We had stakeholder interviews, and that's our professional partners. And then tool refinement happened in January 2026 because the original tool changed quite a bit over the period of the project. And then we had the final usability testing to see whether this tool would actually work in practice and what would be the challenges of actually implementing them. And then the finalized tool, which we've got available, which I know that Jordan would be sharing with the working groups to come afterwards to talk about and to kind of agree the implementation for that. This is just a repeat of what I've mentioned, but just to be clear that the key partners involved, one of the things that I've mentioned that we really appreciate the deep engagement partners and their wider network, but also Jordan's, I keep saying Jordan because she's been a real, I don't know, just amazing in terms of looking at our recruitment. And one of the stakeholders, Kesh Academy, that she managed to get really involved in this project meant that we had really great engagement from very young people, 15 to 19-year-olds. I was the age group, just being involved in this project, sorry, to 17, I think, which was really great because often when we do this sort of survey, it tends to be a lot of adult voices. So it was really great to have the young people involved. And of course, we had in-person and online to just increase our accessibility. And we had sort of the NHS as well as council and voluntary partners involved. So we'll move on to the next slide. So Darlington, because you worked so much on the data, I'll pass this on to you to just give a little explanation about these figures.
Thank you so much, Kelly and Jordan, for organizing this very informative Launch and Learn session. And my name is Darlington. I'm a consultant at Aceso Global. And so this was one of our flagship projects that we did launch, and the data that we has been able to generate has been very impactful throughout the entire process. So as you can see here, when we started the survey, most of our respondents identified themselves as white British. We have around like 125, and Asian British was like around 61. And then throughout the entire a survey, we had a very huge demographic of people who was self-identifying or just clicking on links that can identify them. And then via the focus group, which is one of the very important aspects of this piece of work, because what happens in surveys is that you cannot capture lived experience. So via our focus group, we tend to focus on demographic that have like lower output within the survey. And as you can see, we had around 25 people that identify as Black British and African Caribbean. And then with the usability testing, we tend to do the same thing again. And then we had much more people from also the Black British, African or Caribbean population. And then in total, as you can see, the combined number of how many we have been able to target in this entire research, we were not actually able to match the demographic against each and every component of this piece of work, but we were able to meet our targeted group of people. Next slide, please. Sorry. And so as you can see here, we were a little bit surprised when it comes to how much engagement we received from a very specific age band. Surprisingly to us, we had people identifying between like 15 to 19 years old. had some of like, when it comes to like, the survey, they were people that had like the highest representation, and then followed by people between 50 to 59 years, between like, 55, and then followed by like, people between 40 to 49 years. And then for the usability testing, we also saw that people between 30 to 39 years also have some of the highest like, engagement when it comes to that. And just from like, the gender, we have like, at least 157 female that went through the survey compared to 102 male. And then the same thing with the focus group, we have more female engagement, and then the usability testing. Next slide, please. And so this was one of the biggest, like, output of this entire piece of work. So why going through the entire survey, and then why the focus group, and then the usability testing, we kept understanding or trying to understand what people was trying to tell us. And so these were just some of the few major capstone we kind of took from this. So one of the biggest, like, component of this piece of work where people was telling us that sex and gender question was why they reported as like, confusing, because these are primarily based on clinical or like, languages that people kind of like, noted that created kind of barrier. So some of the teams that we generated from that, and kind of like, just went through the data processing, was this question was confusing, and then the broad category was so much insufficient for many kind of ethnic community. Other people were saying Asian is far too general because a person might be from Asia, they might not be 100% like, kind of Asian, because there are different like, or like, countries within like, Asia. And then uncertainty about how data storage sharing also reduce people willingness to actually disclose on what information we were basically like asking for. And so there were like a few kind of like, points that we were able to get from some of our focus group discussion was like, why do you want this data? People needed us to provide them with the assurance that we want to collect this data for like these specific reasons. And then normally most of the like, issues that we were generating from that focus group was that people were not saying what actually happens when it comes to the data. People were like, we gave data, but we never see what really kind of happens to that. So next slide, please. And so what communities actually ask for within this entire like, piece of work. So people, as you can see, when it comes to the ethnicity and identity, people need like a very kind of like, granular kind of options, right? So there was, we kind of like, co-develop like a two-step approach, which was like, a broad headline group that people can like, identify like a very specific like identity, and then went down into the granular base where people can identify as a smaller base. And then we also included free text responses where people can kind of preset categories, and then we added country or like countries of heritage, so that people are also able to like, select countries they are from. And then when it comes to sex, gender, and disability, we were able to like, separate sex and gender, as people might have like two distinct, like, the two of them might not be synonymous to each other. And then plain English purposes. So that was one of the key bits that we included in this piece of work, that people can actually understand in everyday language. When we say do you identify at this gender, we kind of explain what that specific gender is to them. And also disability was also framed on how functional impact they have on daily life, because a diagnosis is quite different compared to a clinical diagnosis, is quite different compared to what a person might be going through during their daily life. And also we kind of focus on hidden disability and other like, neurodivergence like issues that people have requested. And so trust and data governance was one of the biggest things, especially in this day and age. People want to understand exactly why every single question we ask them, what are we going to do with that data? And so we also have to include like a very clear confidentiality, like, assurance that if you give us this data, for instance, we are not going to like, share this data with police or immigration. We're just going to use this data for this specific purpose that we have asked you for. And then we like automatic disclosure control for smaller groups. So every group that was below like, an equal 5, we automatically like, go through anonymization. So we are not able to identify this kind of group. And so the feedback loop on just this kind of just demonstrate how data will definitely lead to how the service is going to change or how it's going to be impacted. And then the assets and design, we use plain, like in plain English here, there was no clinical or technical jargon. And then there is going to be like a multi-language version and accessible format, as well as smart routing, where if a person kind of click on a very specific question for male, they're not going to see questions that are automatically relating to like female or like, other areas, and then remove the kind of burden of inapplicable questions entirely. Next slide, please, Charlie. Thank you. And so, as you can see, I'm just going to run briefly into this. So before the the initial two had like a 20 broad category, but then after we revised, the two, we had like two-step process where there is a broad and there is a specific category that people can choose from out of the 20 broad category, and then self-identify into granular base of their identity. And then the before two had like one combined confusing question on sex and gender, and then now they are separated into two distinct questions, each having like a very clear like explanation on what gender is going to be and what sex is also going to be. And then the clinical and diagnostic language around disability, the same thing again, like just making sure that a clinical diagnosis is quite different from like an everyday kind of like practical aspect of or disability that a person might have, and how much impact they have on like the daily life. And these were some of the disabilities that we also included. And then all questions showing to everyone. That was one of the biggest like kind of issues we noticed, or things that people were like telling us was, didn't we kind of develop like a smart routing that only relevant questions are going to be like showing. An example is pregnancy question was normally showing for everyone, so now pregnancy question is going to be skipped for like male, like and then language duties also is going to be like kind of skipped for English speakers. And then minimal explanation on purpose, that was one of the also a very key aspect we included. So the confidentiality kind of like surrounding upon the assurance through telling people we need this data. We are not just using like at the top of like the data monitoring form. We say we're collecting the data for this purpose. But every question we ask, we tell people why we need this very specific question. So it gives people the assurance that even though they have agreed to go through this form, they might kind of forget why they are doing this in the first thing. And then the free test responses to also kind of allow people to be able to just initially the free test box was where people can actually like tap in the question, and there was a very like huge number. If you ever work in data, you're gonna understand that a lot of free test response is not super good, because it's like just the text structure can be so different. Now just using like a drop down menu where every country is recognized, a person can just go there and click on that question or that country that they are actually like that kind of relate to where they are from. Next slide, please, Charlie. And also this was the usability testing, like results. So after we have designed and or co-designed each and every bit of this of the piece of work, instead of just producing the demographic monitoring form, and just taking it back to Jordan and the council, we wanted to really test when it comes to the practicality of how this form gonna like work in real life, because in research it is one of the key things, like translating evidence into policy is quite difficult if you don't find like the bridge between these two. Most of your work that you have done with all of the research can sometimes just sit on the shelf, and so we tend to like try to make this very useful. And so this was just a usability testing result. So after, what we did was basically like a comparative design where we have like a two kind of like from the revised form plus the original, and then we randomize like randomly assign people to each group to minimize the other effect, where or one group of people going to complete like from A and then complete from B. Another group of people going to complete like from B first and then complete from A. And so 70% of people prefer the revised two, and 70% also found it to be very, very clear. And then for like better reflect the identity, we saw that 70% also agreed that the new form actually like reflected the identity. And then as you can see, there was only 10% for the original when it comes to the identity like reflection, and then 20% was for the original when it comes to clearer, and then 20% were also which two they actually prefer. Thank you so much. And so this is just like a few other bits, and then one of the key aspects of this is the average like kind of completion time. And so we found that basically like to basically the 2A, which was the original, have like 3 minutes 53 seconds, and then 2B was much more like kind of when it comes longer to complete because it had like, loads of other things that we had to kind of do. But again, like, longer does not really reflect like, the overall reflection of how people identify when it comes to the two. And Kelly, I'm going to turn this back over to you to continue. Thank you so much.
Thank you, Darlington. That's really helpful to have that detail. I think I'm sure Jordan will be much better placed to talk about the immediate action plan that follows this. But we sort of had discussions about what would be a natural next step following the work that was completed. And of course, the suggestions, the recommendations is really about what could be immediate. And it's really about thinking about this revised standard, how that could be used digitally. BLACHIR, the system that's in current use, may not necessarily be able to do the smart routing and things like that. So it's about thinking about how it would sit in terms of digital usage, and then confirming all the conditional routing that was, integrated into the tool. And of course, cross-reference tool with your EIA processes, because you want to ensure that your equality impact is positive with regards to making any new implementation or changes. So that was sort of suggestions for the immediate 0 to 3 months. Moving on, sort of 3 to 6 months, but of course these things are just months that we suggesting as recommendations. I'm sure that some things might be happening simultaneously. And this is about introducing a search filter functionality for sort of longer lists, because as Darlington mentioned, all of the countries are there and etc. So it's just about thinking about that. And then the development of accessible formats. So going into that multi-language, or even thinking about, people who may have, dyslexia and things like that, how that would be, how the versions would accommodate those things. And then, of course, medium term, 6 to 12 months, it's really around training frontline staff. And I say 6 to 12 months, but you may consider doing this at the very beginning, setting up processes. Because obviously for some staff, asking questions about identity is really natural and easy and everything. But for others, it may feel uncomfortable or awkward. So just ensuring that everyone has the opportunity to work through, implementing this new standard. And of course, establishing a data mapping framework so that you as a council, you obviously have to report big data. You want to make sure that things are aligned to the data sets that you would be working with, and obviously the national ONS categories, etc. And then longer term, having this adopted across the system would be ideal. So we know that there are multiple systems used across the NHS as well as the council, and whether there would be a quick win in looking at templates that might be able to be created. And I'm no technician because I know how difficult this could be, but it would be really great if there was a way that it can all be sort of seamless and embedded in those systems, so that you have like for like data across the system. And of course, investing in a platform if BLACHIR isn't necessarily able to be adjusted to accommodate some of the new requirements, maybe looking at a system that can do that. And of course, in the early stages, in the immediate, you might think about using something really simple as a Microsoft form, but longer term, you want this system that is really robust and can manage data changes, because population change, and you may want to actually revisit the tool again in months to come. Okay, I think the last slide, I think this is the last slide, and it's really about limitations and lessons. And I think we've talked about it throughout this presentation. And that is around the sample and, the representation of the population, etc. Really pleased with having 325 engaged. And, you know, we know that it's been a really great attempt in terms of looking at having a good sample, but it's still, there is some insufficient data, as we will all acknowledge, in terms of the design. And, you know, there will be refinements, etc. to come. And there might be some populations that we would want to hear more from in the future. So we acknowledge that there was, you know, as much as we did absolutely everything that we could to reach communities. And I think we have a relatively decent representation. More could have been done in terms of what in the future when, you know, when this opportunity happens again. Small number suppression, expanded ethnicity categories, increased granularity, but may create small subgroups requiring some suppression. So we acknowledge that, and implementation guidance on disclosure control is essential. And I mean, that follows through with the following, which is the local granularity in terms of categories can create some challenges in terms of harmonization, etc. Completion time, I think Darlington mentioned about the different version. Of course, the so-called new and improved version is a little bit longer. So that is, you know, something that can't be held because there's additional routing and more specific categories. But I think because people felt it was better, I don't think that would be too much of an issue. But going back to the Be Heard system that you currently have, you know, you won't really necessarily be able to support some of the new stuff, the new conditional routing and things like that. So that needs to be considered in terms of what the short-term rollout would be versus the long-term investment in the system. So that would be our kind of reflections in terms of limitations and lessons. So I think that I'd leave it there. I don't think there's another slide, Jordan, so I'll pass it over to you now. Thank you.
Perfect. Thank you very much, Kelly and Darlington. That was really helpful and really good to kind of see some of that. I don't think we've actually mentioned it. So for anyone on the call that doesn't know what Be Heard is, for context, it is the council-wide kind of consultation platform that's used for all public consultations. We tested it on here because we know that it was one of the standard platforms that we use in theory across the council. Obviously, there's going to be slightly different considerations and ways that we need to optimize this for different platforms and different services going forward. And just reflecting on some of what Kelly and Darlington said before moving on, it was really good to see that we use this selective sampling to try and get a broad representation across Birmingham, rather than relying on kind of typical communities that normally engage with these types of consultations. In the long term, as I've briefly mentioned, there is a planned mandate for this to be used across all City Council services, but obviously there's a lot of different steps that need to be taken beforehand, before rollout, to make sure that it's something that's going to be useful and something that will work for all. There is also, like Kelly mentioned, some differences between this and this new tool and how the census currently captures information. The expectations is that staff and services would use the more granular options and report on the more granular outcomes as it better represents the service users and residents of Birmingham. However, I am already working on a kind of mapping framework coding system that will enable all of the categories to be scaled up to census categories when we need to for any external reporting requirements, so that it is still going to be fulfilling some of our contractual requirements that I know we have, like in public health, for example. Some of our reporting to OHID or comparisons to other local authorities may need that ability. Some of the other reflections as well, going back to the initial context. So Birmingham will now be able to fulfil that council mandate and collect ethnic data on our Jewish and Sikh communities to reflect it in the ethnic identity category. And the tool enables just more granular data collection across the board with that mapping back. And this research did look at a small evaluation or bit of feedback around that BLACHIR opportunity for action that was around removing colour language from ethnic coding. So the use of terms such as Caribbean rather than Black Caribbean generated mixed responses in this research. So some welcomed the change as less reductive and found it more identity affirming, while others in the groups found it obscured meaningful community distinctions and reduced the ability to self-identify accurately, which directly links back to the two-step approach that Kelly and Darlington mentioned, where someone will tick the broad ethnic category, such as the white, Black, Asian, or other, and multiple categories will be coded as mixed or multiple ethnic groups. And then the more granular identity will allow people a bit more of expression there. So I'm going to move on to what happens next, as this is only the start of the programme and there is far more work to get this moving across the council. So we're taking a phased approach to rolling this out. And as I said, the end goal is to have this across all Birmingham City Council services, including consultations, surveys, externally commissioned work, service user data, etc. In the longer term, we would love to see this approach mirrored by local NHS services where possible to further enhance our local data comparability. So this process will start with internal governance and stakeholder mapping. We'll move into piloting and tool development, and then into full implementation and training with ongoing monitoring and evaluation. So there is, and I will talk more detail about it in a second, an internal working group that will be established that will look at the governance and approval processes. Before rolling it out, we will make sure that all of the implementation tools that we need are created and available, which may include paper questionnaire versions, optimization for different platforms, easy read or audio formats, different translations, having anything else that we need in place, staff guidance on how to use the tool and how to ask for demographic and special category data. There is also a strong focus on messaging to improve trust. If anyone caught from the page on usability testing, the thing that largely didn't change from the first to the second tool was the category around trust. And this was one of the most common challenges we saw throughout this project. I revisited all of the Be Heard consultation data from the previous 12 months, and the type of comments around why Birmingham City Council is collecting this data appeared in almost all consultations, that people would look at specific questions around demographics, for example, disability, actively click other and go, why is the council asking this? Why is this needed for a new road design? And I'm going to bring a bit of an anecdote to bring this to life, to show the importance of demographic data capture within council planning and delivery. Because when I first saw these comments, it almost made me go, well, actually, why do we need this? What is the purpose of this? And I can see someone in the call that's going to love this analogy, that I'm going to share an example from a book I recently read from a colleague who lent it to me called Invisible Women, which looks at the gender data gap and the real world consequences of not involving women in data collection. So a section of this book took a deep dive into public transport design, specifically looking at bus routes. And historically, it noted that many transport systems were designed around a very linear model of movement, people travelling from their home into city centres in the morning and back into the suburbs in the evening. And this pattern tended to reflect traditionally a more male commuting journey from home to work and back. But when researchers looked in more detail at how women were using the public transport, they found a very different pattern and were more likely to do what was called trip chaining, so taking multiple shorter journeys in a day, dropping children off, visiting relatives, going to medical appointments, running chores, and then potentially travelling to or from work in that same inner outer city journey route also. Because these bus routes didn't reflect that more complex local movement, and often lacked really good connections between suburbs, it meant that women's journeys on average took longer, required more transfers, and were generally more difficult. This was research outside the UK. I can't remember exactly where, but just for reference. And what was powerful about this example is it showed how design decisions that seemed pretty neutral can actually disadvantage certain groups if their needs aren't represented in the data and in the service planning. So when cities started redesigning routes to better connect outer city areas, it's not just something that then only improves the use of bus routes amongst women, it improved the accessibility and convenience for everyone using the bus journeys. And that's the same principles that I wanted to take on board here, that if people aren't properly represented in our consultation data, in our service data, systems can unintentionally disadvantage them, and accurate and complete demographic information can improve local services for everyone. So quickly on the next steps, a key part of implementation is a newly established working group starting tomorrow and running on the third Thursday of each month. And this group will be really core to support implementation across services and ensure consistency, alignment with governance and approval routes, and ensuring practical usability throughout. So through our current membership list, there is also links already into multiple different council directorates and a range of existing structures such as the Health and Wellbeing Board, the Equalities Board, and the Corporate Data Group, to name a few. So we're really keen to expand this group, particularly bringing in more operational, analytical, or community perspectives. So if you're interested, we'd strongly encourage you to join, and the contact details will be shown on the last slide. This also is open for joining for people outside of Birmingham City Council staff, as I want to reiterate that citizen voice and involvement has been a core part of this to date, and I think it still remains a core part of embedding and implementing this across the council. But this group will be really core in making sure that we have all of the approvals necessary. We've gone to all of the right people. We have all of the right processes in place, that when we are then due to launch it across all services, it's a smooth process and we have everything we need to make this work. So in a quick to finish, what can you do? I've tried to map out a couple of really broad things for different people attending this webinars on some of the calls to action. So if you are a Birmingham City Council staff member, it would be great to actively support the rollout and embed the tool when the time comes within your service area and directorate, and also include the tool in any public consultations, surveys, service design, etc. If you're an NHS or other healthcare partner on the call today, I am aware that you may not be able to have influence over electronic patient records or data systems in that capacity, but there may be some ways to align your approaches and engage in shared learning. So for example, in a different group I work in, one of the local NHS trusts has just recently redesigned how they collect ethnicity data in their patient feedback surveys, and those are potentially some routes that could be adopted onto this consistent approach without the need for access to centralized data tools. And if you're a resident, I would appreciate the kind of continued and shared experience and learning of providing demographic information via the new tool, or more in general, feelings of trust towards the council, and really help us make sure that we shape a system that better reflects identity and need. And that brings us to the end of our formalised part of the Lunch and Learn. So I think, apologies, we've run a little bit over what I planned, but we still have the best part of 10+ minutes to run through any questions that people may have. While any questions in the chat or hands are raised, I will also pop up this slide on further contacts and links that for email for joining up to the core group. That will be myself or the BLACHIR inbox. For anything about our wider pieces of work, including the BLACHIR work, which is where some of these recommendations came from, or the Deep Engagement Partner Programme, which is where a lot of our community engagement work sits, are linked to there, and also just to our Birmingham Public Health Eventbrite page, as there is a couple of other upcoming events different to this but may interest you. So I will end this part of the webinar and come to Q&A. So I can see 2 hands. So number 1 is Joe.
Hi, Jordan. Really good presentation and really good work with everyone involved, and can see a lot of value in it. Just for people on the call, I'm a service lead for mental health and wellbeing, so it'd be good to hear how that relationship is going with local NHS and ICB in terms of, I know, long-term kind of view of integrating this into the BSOL footprint. I see huge amounts of value across the council, but even wider across NHS services. Obviously, from my point of view, mental health services, where this could bring so much value in terms of understanding some of the health inequalities that communities face within Birmingham. So just wondering how that's going at the moment, and yeah, how they can be more part of the journey with us along the way.
Absolutely. Thank you, Joe. So two kind of main things on this is one, throughout this research, it briefly mentioned that we had some stakeholder interviews. One of those interviews was with the chief analyst for the ICB to help provide some of those recommendations and guidance of how this could work. And I think the main group that I'm going to target first is I also sit on a BLACHIR ICS task force that the Community Healthcare Trust hosts. And because this fits into a lot of our shared objectives around improving data as we're all working towards that same better data outcome in the BLACHIR review, that is the group that will kind of help operationalize this first, as we have quite close relationships with primarily then the EDI leads in a lot of those different trusts. I'm not sure if anyone's on the call from that and I'm calling them out there, but that will be, I think, the first group that I try and roll this out with, because obviously just getting this across all council services is going to be a huge task to get things consistent. And we all know that the local healthcare system is huge and now expanding with the inclusion of Black Country. So I think it's going to be a pretty long process, but that's how we're involving the ICS colleagues initially. So hopefully that answers your question there. Perfect. Next hand is Kate.
Hi. So we are one of the deep engagement partners. Unfortunately, because of work, I wasn't able to actually attend any of the meetings. So I'm very interested to see how the Chinese community have been dealt with, if you like, because there's a lot of issues around demographic stuff, the identification, and Chinese in itself is, in parts of the Chinese community, hugely problematic. So I'm very interested to see how that works.
Of course. So currently the actual category for ethnicity has remained the same as Chinese. There has been an expansion in the country or place of heritage and identity to enable a bit more flexibility. But like Kelly and Darlington mentioned, it's not a static process. So if there is still availability to kind of have more in-depth conversations about anything that you would like to see changing in future iterations, I'm more than happy to have a more in-depth conversation as well with you, Kate.
Thank you.
No worries. Next hand, Kafila.
Hi, Jordan. This is fantastic. Just want to say well done to everybody that's been involved. Really, really exciting. Just wondering if there would be an opportunity for us to work alongside you in regards to you might have seen the updates around the mobile cervical screening project, which is now being expanded by the NHS England team. We're hoping that it's going to be sustained. But because that data is managed directly by myself, we could start essentially helping collect, being guided by you in the group, and co-produce how we collect demographic data and feed that back anonymously, if you'd want us to be a part of that and work alongside in real time to show you, what people select, because I'm seeing that. We're working with Paulus and Helen Bissett, and we've used the broader categories, but I'm constantly seeing the other box being ticked, which again is frustrating because it feels like you're not representing people correctly, and especially for such a diverse place as Birmingham, which is densely populated. I'd be really, really keen to work alongside, because this is all about inequalities, like you said. How do we build trust with communities when they don't feel represented? And we're going on about being inclusive and accessible. But yeah, if you'd be interested in me joining and inputting, I'll do as best as I can. I'm juggling different hats at the moment. But yeah, well done, everybody. Really, really exciting.
Thanks, Kafila. And I don't know how you have the time to do it all. I feel like you always are juggling a million things. And thank you for the nice comments. And for anyone that's not familiar with the Cancer Tour Bus, I'm so glad to hear that it's kind of being rolled out. It's a brilliant initiative and a brilliant programme that we have in Birmingham, mainly thanks to Kafila here and the rest of the team. But I would absolutely think that would be a great opportunity to collaborate here, as it's a great then kind of healthcare NHS link into this programme that I think we can really easily do that. So I'll absolutely be in touch with you around that. Thank you, Kafila. Next hand, Famous.
Yeah, thank you for this opportunity, and I'm grateful for this meeting. Yeah, so I've got a question from Mrs. Kelly. Yeah, she mentioned something about Google Forms, and she said because they're not too robust, which is very true. But I know Google Forms are used to create some surveys and questionnaires. So my question is there anyone that you've got in mind to use? I mean, is there anyone that's going to be suitable for this survey, for this program?
Hi, thanks very much for the question. Yeah, I think I was referring to maybe some short-term kind of management. I know long-term would be great to have a system that is fully robust and can do everything that we'd like, and it works for everyone in the system. But sometimes in the short term, and you may want to test something immediately, you might have to use things like the Microsoft forms that exist to do some of the questionnaires and all of that. So I was suggesting that maybe in the short term, for the kind of implementation practice, if you like, that you might have to use existing tools like the Microsoft Forms as a holding space until something more robust is built. Now, I can't say this. I suppose this is better from Jordan, who would be best placed to build that robust system. I'm sure the council has a whole procurement approach for getting technical buds to develop any system. So I will pass that one on to Jordan to kind of describe what that process might be.
I mean, the first step of that is working with the core group to actually map out what different platforms and systems we use across all council services, because I think being such a huge council, I would be silly to say that I'm already aware of all of the different platforms that we use. So the core group will have representatives from each directorate that can give us some more information on what the different services use, what some of our commission partners use, if there is already some kind of consistent platforms used across specific directorates that we can really jump on, or if we do need a bit more of a revised approach to looking at how the council collects data as a whole. I think that again is a much longer term process, but initially, like Kelly said, we'll look at optimizing it for some of the quick wins. Things like the Be Heard platform will hopefully be able to optimize it for within the next month or so. Having a Microsoft form that can be used for quick surveys or small work within informal focus groups, etc., that we can share out, are just things that we can do then in the immediate term. And what we'd really like to try and do with all of this and having that view of all of the data systems is to make this the default option, regardless of what system is used, just so it's easy for every service user. So I keep going back to Be Heard as it's the one I'm most familiar with this program. We will be updating when you click a consultation, it will have an About You section. You just automatically click it and it will populate with all of the questions from this demographic questionnaire. So it is the easiest option to use. So there's lots of work and different strands to figuring out the different platforms and different usage of the demographic questionnaire. I know that was a bit of a long-winded answer, but hopefully that answers some of it for you.
Okay, thank you so much. I've got one more question, please.
Yeah.
Yeah. So upon I mean, normal people that are outside staff outside Birmingham City Council and the NHS, how can we be part of this program?
Sorry, what was that? Have they already been part of this program? Was that?
No, how can they be part?
Yeah. Sorry, the sound was a bit quiet on that end. So there's several different ways. Like I mentioned, that the core working group is going to be the main place for people outside of the council to get involved with this. I actively encourage participation outside of Birmingham City Council. Although over the next couple of months, our main focus is going to be really on looking internally, it's still always useful to have that external focus for residents, NHS, or any other organisations that want to look at how they can be rolling this out within kind of different settings. So that's how they can be involved going forward. Thank you.
Yeah. So what do I need to do? What do I need to do? That's the question. Sorry.
Oh, email one of the accounts on screen and we can have a further conversation to get you involved.
Okay. Thank you.
Thank you very much. Next hand, Fahana. You're right, Fahana.
Hi, Jordan. Thank you. Yeah, it's first of all, well done to everybody involved in the creation of this tool. It looks brilliant. It looks just like what we need really to gather better inequalities data and analyze it. Just a question, just with regards to, although I understand that there's an explanation of why this data is being collected and how it's going to be used, etc., within the tool. I just wonder whether, given the lack of trust there is in the provision of such data and I just wonder, was there any feedback within the sort of the focus groups and the sort of surveys, etc., the ways that you collected information on whether we need maybe some kind of a campaign to actually raise awareness within the wider communities across Birmingham as to why we are gathering this data? Because what we can provide within the tool is only limited explanations. And do we need a wider campaign to really encourage as many people as possible who are going to be coming across these forms to give that level of data that we now are asking them for? That's all. Thank you.
I see Darlington's already got his hand up, so I'll let him come in first.
Thank you so much. That is a very good question. And just kind of looking back at some of the focus group, one of the most important aspects that kind of came forward is that every time, like demographic changes, people always love to be involved whenever it comes to designing things that actually affect them. And that was one of the key points that we actually get from the focus group, was that we need to go back to people and get them involved. So that could be either through a simple co-designing or community-based participatory event for us to, for the council or whoever that is collecting that information to be able to present the idea that this is what we want to do in the future. Is there a way that we can reframe this idea to better suit your demographic or your population? And then people have pretty amazing ideas, especially when it comes to things that actually impact their health. So that was one of the major kind of aspect we get. The second major bit was that a lot of time it's always good for people to be involved via trusted leaders. As you can see, in most of our focus group activity, what we did was we engaged with organizations that has already been doing work with a very specific community. So rather than us going in as researcher or to kind of co-design this activity, we went through via this organization, and then we train the leaders of this organization to be able to actually perform or to conduct the research. So in all of the focus group, what we did was we were just guiding the process, but we were not the one who were actually doing the research. So most often, we were just going around looking to see how the entire process was going, and that actually reiterate people trust in how they trust the system, rather than us. Initially, what happened was through the survey, we saw how people had so many, when we were analyzing the data, has so many people actually had trust compared to after we had the focus group. We saw that kind of trust issues started almost kind of going down a bit. And so I think it's probably because we went and we had community leaders or organizations that had been working with people for a very long time. We went to them to kind of just embed the research into that culture, so that we cannot be seeing a new phase or seeing authority that is just trying to get data from people, rather than just telling people we need this information because we don't know how to do it. We need your input in how we can better design this. Yeah.
And I'll
Thank
just
you. That
add on
sounds
to-
like it was empowering and engaging at every level. Thank you.
Can I just add on to that as well? Thank you, Darlington. And it was a really core part of the design process to have, say, community-led and community involvement, as that really did improve the trust from those involved in that process. However, I do still think that there is something more to be done, as we saw then from the usability testing, which was people that hadn't been exposed to that process to date. 80% of them still said that there was no difference in how trustworthy they felt the tool was, that it was still a council-led tool. And you're absolutely right, those short descriptions in its own is not enough to say, yep, I now trust the council with my data. And there's both a external and internal component to this, in my view. So the external component absolutely around really making it clear why the council does ask for this information and how is it relevant, and how will providing this data help the council improve and deliver services. But then also an internal piece of work around making sure that a lot of staff are residents too, and may also have the same questions on, well, why is it relevant? Why do I need to include it? Why should I consider it? How do I then capture this data and actually use it in ways that are going to be impactful? So there is kind of a two-pronged approach to this, I think, with the trust aspect of this. Thank you. Okay. I know we're running over, so apologies everyone, but I will take another couple of hands for anyone that can remain in. So next hand, please. That's Farhat.
Hi there, thank you. yeah, brilliant piece of work you've done, so methodical and logical, and I can see it bringing so many advantages. We work with various partners right across the city, and the point that Farhana just raised, I completely echo with that and the kind of things that we're hearing. And I suppose it's more a comment that it's perhaps other work that needs to be done for all of us around trying to reduce the stigma and fear around people sharing their information, and just making it clear what that data is going to be used for, and make sure we only use it for that purpose, and that it's not going to be shared elsewhere, particularly in the current climate where we're at. And it just brings, a lot of fear to people. But that aside as well, we work with one organisation where the other box that is ticked is within LGBT communities. And I find that some of the trans communities and some of the population groups within that just don't share. And the other box is the biggest tick box, not tick box, but the biggest category that shows up for a service specific area. So it just shows how much other work that we need to work on. So this is good because it supports once we've sort of tackled some of those issues as well. But thank you.
Thank you so much for both of your comments, and just on a bit of both of those points. So in terms around stigma, this is something that we have considered as well, that there is going to be just that trust issue for people not wanting to provide personal information. And I had a conversation with a colleague in the office the other day around, although we'd want this tool to be used in its entirety across all services, if there's strong rationale to be like, if I engaged with this group and included postcode, included this element, it would be a hard no. Is there kind of a process we can follow to make it clear that people can log why they've not included certain questions, to make sure that getting 80% of data from someone would be better than 0%. So looking into kind of a consistent process there, and completely agree around the kind of the trans community and kind of the trust, especially with some kind of national rulings, I think, hindering trust that we've seen in recent times. We're really thankful for this programme that we have had some of the redesign of the sex, gender identity and sexual orientation question with heavy consultation with Birmingham LGBT, who provided some really clear guidance on what works for them working with LGBT plus communities in Birmingham, and making sure that it aligns with what they've used and tested as well. But there are obviously, I think, with all communities, the element of trust that we need to address in the data collection, which is, I think, a huge piece of work in itself, but something really important to show that we are using the data for its intended purposes and that we can keep people safe while doing so. But thank you for your comments. Any more questions? I think that's the last of the hands I can see. What I will do is close down the webinar and stop the recording. And if there is any other questions that people would like to ask outside of the recording, though, I will be able to hang on for a bit to do so as well. But for the time being, thank you so much, everyone, for joining today. I hope you found it useful, and I hope we can engage further going forward.
And thank you. I just wanted to